So it's my pleasure to welcome Mills and Dorien Kimenai to talk about their work on myocardial infarction. And the usual rules for our seminars apply. We keep these informal. I believe it's a tag team talk, and you can look at the meeting chat. You'll see a little message there from Rebecca giving you a few instructions. What's usually helpful, we'll have questions at the end. If you've got questions that occur to you on the way through, just put them in the chat, and then what I'll do is pick them up at the end and we'll go through those. If you haven't put a question in the chat, that's okay too, because I'll give you a chance to speak up at the end. We quite like these to be discursive if we can. But I'll turn it over to Nick now, I think, to lead us off.
Well, thank you very much, Dave. Thank you for the invitation. It's a pleasure to be part of the HCR UK network in the UK, which is enabling lots of fabulous research using routine data. So the focus of this seminar is how we have been and can use routine data to support research around heart attacks. And I'm going to be speaking together with Dorien about some unpublished data that we've been generating using routine data in Scotland and in Sweden to help us understand a little better how to diagnose and care for patients with heart attacks. I have the task of giving you some background first to put it into context, and we'll then, in the second half of the talk, focus a little bit on routine data and the strengths and limitations, I think, of using it. Just firstly, a couple of declarations. The research that we're sharing is broadly funded by the British Heart Foundation and HCR UK, but I have worked with a number of companies that make assays in this space. We've used Stepped-wedge cluster randomized trial methodology with routine data, which I'll go through briefly. And then we'll talk a little bit about some unpublished data looking at long-term outcomes from those trials, and then some of the learning we've had from using routine data compared to the gold standard adjudication according to what is described as the universal definition of myocardial infarction or heart attack, which I will briefly go through. So the reason we have a universal definition of myocardial infarction is that across the world, around 20 years ago, there was a kind of recognition that different hospitals, different healthcare systems were using their own criteria to diagnose what is quite an important condition to get right. That made it difficult to compare research outputs, epidemiological studies, quality improvement programs around the world, and there was a need for a consensus. And you might think diagnosing a heart attack is pretty straightforward. It's kind of my day job. Certainly I can make it look quite difficult. Essentially, it's the application of cardiac biomarkers, and the only one that's recommended now is cardiac troponin as a marker of injury to the heart in patients who present with symptoms or signs of ischemia. And unfortunately, those symptoms and signs can be quite subtle and quite challenging, and therefore often the diagnosis is backed up with some form of imaging, usually a test called a coronary angiogram to look at the heart arteries, but also echoes and MRI scans. So that's the rationale for having a definition. And it was introduced, as you can see from the reference, back in 2007, and it's gone through a couple of iterations since then. One of the important developments was to recognize that actually these biomarkers of heart injury are commonly elevated in other settings. And so the concept of having something other than a heart attack is quite commonly established in clinical practice. And so the universal definition is trying to put a framework around that, differentiating type 1 myocardial infarction, which is a more conventional definition of a heart attack due to a blood clot in the coronary arteries, from type 2 myocardial infarction, where it occurs in the context of another illness that puts stress on the heart. But there's also recognition that it can occur after procedures, and you can get injuries to the heart due to other mechanisms. So it is somewhat complex in clinical practice to make the diagnosis. Of course, the reason it's important to get the diagnosis right is that, unfortunately, if you miss a presentation with chest pain or ischemia, due to a heart attack, a late presentation, or full thickness infarct has a very high complication rate, including sudden death and a variety of other structural complications of a heart attack. So when it comes to changing the way we diagnose a heart attack, it's quite important to get it right and of course to systematically evaluate it. And our first step to doing this using routine data actually began over 10 years ago in Scotland, where we used routine data just to evaluate this initial concept from the first universal definition, which brought with it the use of lower diagnostic thresholds for cardiac troponin. And we did a very simple before and after study in a single center, demonstrating that if you measure using a more sensitive test in the background for 6 months in people that aren't recognized in clinical practice as having a heart attack, those with a positive test have pretty poor outcomes, suggesting the damage is real and it's important and we could do something about it. And then when you introduce the new test and threshold into practice, we found that their outcomes improved. But this is pretty low-level evidence. It's quasi-experimental, it's not randomized, and there could be other time-varying trends for why these outcomes improved. So when it came to the introduction of the more sensitive test, high-sensitivity test, which came in this country in 2013, I think we were one of the first sites to introduce this in the UK. We wanted to do something more rigorous and systematic. And we now have tests that can measure cardiac injury even in healthy individuals, which presents an extra challenge for how we interpret them and differentiate what is an important and not important injury. And it's inevitable that if you continue to lower the diagnostic threshold for myocardial infarction, although the sensitivity will improve, the specificity will also decrease. And that raises a challenge for clinicians to know who to investigate and who to treat. So when it came to introducing high sensitivity cardiac troponin, we did it as part of a Stepped-wedge cluster randomized trial, which reported in 2018. And what I want to share with you today is the outcomes from longer term follow-up. But the hypothesis was that the introduction of this more sensitive test, by recognizing more patients with injury to their heart, would lead to better treatment and a subsequent reduction in future risk of a heart attack or cardiovascular death. And the Stepped-wedge trial allowed us to implement this across 10 hospitals in Scotland to give us a fairly large sample size, to give us confidence whether it was helpful or unhelpful. And I should point out that the reason we did this as part of a randomized trial was because we felt there was equipoise, and it was possible that there would be harm to patients by over-identification, investigation, and treatment when they didn't have acute myocardial infarction. Just on the data, we built our data infrastructure for this trial across 10 hospitals using the Safe Haven networks in Scotland, specifically the Safe Haven network in the west in Greater Glasgow and Clyde, and the one in Lothian, Dataloch. This also required us to work with the electronic patient record system and e-health departments, because we wanted not to have to approach patients and involve them directly in the trial, but to evaluate how routine care clinicians used these more sensitive tests in practice. And therefore, we got the clinicians responsible for patients to enroll for us by embedding a screening tool in the ordering of the test. And we did that across all 10 hospitals, which allowed us to define the inclusion criteria and exclusion criteria by the individuals ordering the test. And then we used linkage to the assay platform, the patient record system, prescribing, outpatient prescribing in Scotland, a variety of investigations. But also crucially, because it was a diagnostic trial, rather than relying on routine data for the primary outcome of the trial, we adjudicated all subsequent hospital admissions across all of these sites where troponin concentrations were elevated. So we had a remote access adjudication console to ensure the data were highly reliable. And the one other feature I just want to draw your attention to is that we also, to build another control into this trial, measured both the new test, the intervention, and the old test in parallel in every participant. In the validation phase, we didn't report the results of the high sensitivity assay. We continued to report the contemporary assay, and then following implementation, we switched that over. And that allowed us to very precisely define throughout the trial those that would potentially be reclassified by a high sensitivity assay and whose care might be anticipated would change, improve, or deteriorate. A couple of methodological considerations just about the use of a step-wedge trial. Step-wedge trials are a useful way of evaluating the effectiveness and safety of interventions that have known efficacy. So we knew that the more sensitive test had slightly better diagnostic performance than the old test, but we didn't know what impact that would have on clinical decisions or on patient outcomes. It's also a useful design where it's impractical to randomize individual patients. And I think the chaos that would have ensued if we randomized patients side by side to two different troponin tests and thresholds for heart attack would have been made it impossible to deliver the trial. I think the other important consideration is that we wanted to be clear what the benefit of the test was as it was used by the usual care clinician, not in a highly selected population of patients who are low risk. We wanted to enroll patients who are at high risk of dying and were admitted out of hours at the weekend. And therefore, we had to enroll consecutive patients to really understand how the test was going to impact on care. The cluster randomized trial, step-wedge cluster randomized trial, differs from a traditional cluster trial in that it allows both within site before and after comparisons, as well as a more conventional parallel comparison in a cluster trial. So there are some additional methodological strengths to doing it as a step-wedge design. And we hoped that our findings would be more generalizable as a consequence of being able to do this across 10 different hospitals, some smaller district general hospitals and some tertiary centres. And the main advantage is, of course, we thought that it might be cheaper and easier and cost less resource, and it was funded by a research charity. The limitations are that the power of a step-wedge trial is determined largely by the number of sites and this variable called the intercluster correlation coefficient, rather than the number of participants. And that does create a challenge, as there's only so many hospitals in Scotland and now in the UK we could potentially use with the broader data infrastructure that exists today. The other challenge is the data quality is considered lower by some, and therefore we put in place an adjudication and endpoint committee. And as you can imagine, the governance and regulations around the use of routine and consented data is complex and continues to evolve. So there are some challenges in doing this. I'm not going to go through the primary outcome 1 year data in any detail, other than just to say that in those reclassified, we did not demonstrate a significant improvement in outcomes. The event rate was 15% in the validation phase and 12% following implementation. And in our primary analysis, that was not statistically significant. But the number of events was a limitation, and therefore one of the advantages of delivering a trial using entirely routine data is that we have the opportunity to follow patients up long term. We had a pre-specified secondary analysis to look at the event rate at 3 and 5 years. And we've just very recently got linkage to enable this. So a couple of considerations with the secondary analysis. First of all, we have a primary outcome here, which is subtly different from the primary outcome at 1 year because we are not adjudicating events. So we opted for myocardial infarction or all-cause death as the most stable and least likely to be influenced by bias outcome. We have a number of secondary outcomes, though, as well, including looking at ICD-10 and stratified causes of death into cardiovascular, cardiac, and non-cardiac. And we've also looked at heart failure, stroke, and hemorrhage. We got these data linked using the National Safe Haven in Scotland through EDRIS, and we linked data from the Scottish Mobility Record and the Record of Deaths. We had a couple of definitions which are quite difficult. Bleeding is quite difficult with routine data, but we used the BARC Research Consortium definition, which combines ICD-10 codes and OPCS codes to define bleeding events as major hemorrhage. And so this is the primary outcome at 5 years in the group that were reclassified. So in the blue, we have outcomes following introduction of the high-sensitivity test into practice, and in the red, outcomes in those that were managed prior to introduction of testing, where the injury was not recognized by clinicians. And the curves do diverge relatively early and continue to separate over time, and had an absolute risk, a relative risk reduction of 18% and an absolute risk reduction of 8% in the primary outcome. And I'll just show you, these are the breakdown of the components of the primary outcome. So if we look at the two composites, myocardial infarction and all-cause mortality, both were significantly reduced. And there were similar trends, I think, for the other causes in the right direction, but not statistically significant. I don't have bleeding event rates on there for some reason, but there was no excess in bleeding associated with the introduction of testing. Now, one of the advantages of adjudicating the outcome, and this is going to become the main focus of the next aspect of the talk, is that we were able to stratify the population based on the initial diagnosis. And our original assumption was introducing this more sensitive test would identify more patients with spontaneous myocardial infarction, or type 1, who might have been missed using a less sensitive test. But as you can see in the left-hand panel, although there was a modest improvement there, it wasn't statistically significant. In the group in the middle, type 2 myocardial infarction, these are patients who come into hospital anyway with another illness that puts stress on their heart. And usually they are hospitalized and treated for pneumonia or another condition. Therefore, perhaps not surprisingly, the introduction of the test there didn't make any difference to care because they were already admitted and they already received high-level care and review. The group where all the benefit was achieved, to our complete surprise, was those patients who were classified by the adjudication team, who were blinded to the study phase, as having non-ischemic myocardial injury. That's injury to the heart, not principally due to ischemia. And this surprised me at first, but the more I thought about it, the more logical it was, because this is a group of patients who don't have symptoms or signs of ischemia. In fact, the only thing that marks them out is high risk, and they are just as high risk as the other two groups. In fact, I would even argue of the highest risk population. The only thing that marks them out as high risk is the abnormal blood test result. And so in this group, hospital length of stay doubled. They were more likely to come into hospital and to undergo further evaluation. Whereas in the validation phase, they weren't recognized as high risk and were less likely to be admitted. And so I think, having spent 5 years doing this, it's only actually once I got the results that it dawned on me that this might be the most likely group to benefit, and indeed it appears to be. So intriguing results showing the benefit, I think, of having the ability to use long-term follow-up to see what happens to these patients within the healthcare system. Now, I'm going to pause and hand over to Dorien to present the second aspect of the talk.
Hello, everyone. It's really nice to have you all here. So I really appreciate that you all are stepped into this talk. I would like to also say thank you to Serena and Rebecca in particular for the invitation. I appreciate the idea that this is just a very informal talk and that we can also discuss further about, I think, a very important topic. The data I'm going to present today is we just recently finished with the analysis. And the reason why Keelan is also presented here in a picture is because he has done an incredibly good job of doing the analysis. And I think this is just really a nice team effort. I would like to have my presentation about the application of the universal definition of myocardial infarction. And if you think about the concept that we have tried to do to make an effort of making a universal definition, I think in a basis that is just an extremely important element, because I think ultimately what you hope with making a universal definition is that you are improving the outcomes of the patients who you identify for that particular disease. And in our case, that is heart attacks. And I think it's great that we have done that effort over the years to make a universal definition, to make sure that we also can do research and that we can not only directly have impacts on patient outcomes, but that we can also improve that over time. I think another great element is not only of making a universal definition is also that it is endorsed by the international guidelines, and that is also a very important step. That also this document is not only just a theory, but that it is also should apply in practice. But actually how we are doing it in clinical practice, that is pretty uncertain. We actually didn't know. So that is the main research topic of today, that I would like to show you some data on actually how we are applying that universal definition. And for this research question, it is important that you not only look at one country, because it is important that if there are differences across countries, that we also have a little bit of understanding why we don't or do apply this universal definition. And I want to particularly focus today on type 1 and type 2 myocardial infarction. And I think most of you will be more aware of the definition of type 1 myocardial infarction, which is more the classical heart attack. Well, for type 2 myocardial infarction, it is not related to primary atherosclerotic events, but it is a secondary cause and the result of an oxygen demand disbalance or imbalance. I'm sorry for that. So this type of patients is a very vulnerable group of patients, and maybe sometimes also a little bit of a forgotten group of patients. But if you look at the outcomes, then you should realize that this patient group, that's 2/3 of the patients are not alive anymore at 5 years. And also, if you look at cardiovascular events, they are very similar with type 1 myocardial infarction. So it is really important that at least we apply to that universal definition and that we make sure that we identify them in clinical practice. So in this study, we've evaluated the application of the universal definition. We've done that across different healthcare settings. And additionally, we also have evaluated clinical characteristics and outcomes between those patients who did and did not receive a clinical diagnosis of type 1 or type 2 myocardial infarction. We have used 2 large multicenter studies of consecutive patients with suspected myocardial infarction. And what both studies have in common, and that is also why we are able to conduct this study, is that both these studies had an adjudicated diagnosis of myocardial infarction. And for anybody who's maybe not so familiar with the terminology adjudication, the way how it worked in both these studies is that there have been 2 clinicians who have independently reviewed the records of that patient and made the decision whether that patient had a myocardial infarction, and if yes, what the type was of that particular myocardial infarction. And if they disagreed, then a 3rd person stepped in. So it is a very systematic way of making a diagnosis, and it is also a really good gold standard. That allowed us to actually compare that gold standard with a clinical diagnosis of myocardial infarction. And we have defined the clinical diagnosis by the hospital discharge diagnosis codes. As I said, we have used data from Scotland and from Sweden. So for Scotland, we have used the High-STEACS trial, of which Nick already briefly explained the principle of the original study. So we excluded in total approximately 19,000 individuals, also for the reason that we didn't want to have included patients who had a contemporary troponin assay. So we only have included those with a high sensitivity cardiac troponin assay, and also we could not adjudicate the diagnosis, but that left us with approximately 30,000 patients. For Sweden, that original registry had a little bit of different purpose. So the initial purpose of that study was to identify only type 2 myocardial infarction patients. So the flow of ending up with a similar set of patients was a little bit different. But for the Swedish data set, we ended up with a total group of over 20,000 patients, which we have evaluated. So we use the clinical discharge diagnosis codes for the clinical diagnosis of myocardial infarction. For Scotland, we used the Scottish morbidity records, the SMR1, and for Sweden, we have used the Swedish patient register, and we've collected all the hospital discharge diagnosis codes from the index diagnosis. And every patient that had an ICD-10 code of 121 or I-22 was being diagnosed as having a myocardial infarction. And for those who are using those SMR1 records, also know that there are different positions you can choose. For the purpose of the presentation, I will present only the data where we have used all positions, but also in sensitivity analysis, we have looked whether it matters if you only look to the second or the first or the second, etc. Position. So I'm gonna present the data basically in 3 bits, where I first will show what actually the agreement was between the gold standard adjudicated diagnosis versus the clinical diagnosis. In the second part, I am gonna show you some data on actually how the patient looked like who did and did not receive the clinical diagnosis. And I will end with showing the cumulative incidence of myocardial infarction or death from cardiovascular cause between the groups who did and did not receive the clinical diagnosis. So what you do see here on the left is a sunburst plot, and the way how that is built up is basically the inner ring is the adjudicated diagnosis, and you do see the proportion of those who are getting a type 2 myocardial infarction is lower as compared with type 1 myocardial infarction. But what you hope to see is that they were all being recognized in the clinic as having a myocardial infarction. What we did see for type 1 MI is that in the clinic, approximately 80%, the gray part of the outer ring is being recognized as having a myocardial infarction. While you do see for type 2 MI, that is a very small proportion. So that is basically around 1 out of 5 patients that we have been identified as having a myocardial infarction, which is much smaller. And we did see a very similar pattern when we looked at the Scottish data, that also approximately about 1 out of 5 patients who are having a type 2 MI, according to our gold standards, is in the clinic being recognized as having a myocardial infarction. That is also expressed in the diagnostic accuracy, where that is much better for type 1 than as compared with type 2 MIs. And also when you express that in a Cohen's kappa, which is basically also telling us something about the agreement, and perfect agreement would mean 1 and 0 is extremely low. Then you do see that type 1 MI is actually doing it pretty good, and type 2 MI is just, yeah, we do see that the clinical diagnosis is not in agreement with the adjudicated diagnosis. We have done some exploratory analysis to also look and do we actually see a change over the time. So what we were hoping to see is that at least for type 2 MI in particular, that the proportion of type 2 MI in clinical practice would increase over the time. And I want to be a little bit cautious with the Swedish data because also the sample size, and when you divide it in blocks, we are a little bit limited there. But if we look at over a 6 months time period over the time, then we actually don't see any differences for both type 1 and type 2 myocardial infarction. So yes, when you are going to look to those who are not been identified as compared to those who are, then what for me I did find interesting when I looked at the Scottish data is that when you have a type 1 MI, those patients are younger as compared to those type 1 MI patients who are not having a clinical diagnosis. And also they are more likely to be male as compared to those who are not getting a clinical diagnosis. For type 2 MI, there is no difference between age and also no differences in sex between those who are and are not received the clinical diagnosis. What we did see is that for troponin, we did see an agreement between both type 1 and type 2 MI. So the higher the troponin levels, the more likely it is that those patients did receive a clinical diagnosis. We did see a similar pattern also in the Swedish data. It was a little bit less remarkable as compared with the Scottish data, but when you look at the pattern, that is pretty similar as compared with what we did observe with the Scottish data. When we did a multi-variable analysis to see which one are actually really the strong independence predictors, then for type 1 MI, H and 6 were still independent predictors. So that means that the older you get, the less likely it is that you are being identified as having a type 1 MI. And it is also that if you are a male or a female, then you are also less likely to be identified as having a type 1 MI. Similar to that is that we didn't see the differences for type 2 MI, but we also didn't see that already in the unadjusted analysis. Troponin remained also a strong independent predictor, and the same is true, or you do see here the 4 variables like ischemia, eGFR, and troponin that were also independent predictors for type 2 MI. And it was less strong again, but that is already the result what we did see in the unadjusted analysis. But I find it really striking that are particularly also H and 6 that are so dominant also for type 1 MIs. And we made the next step to also look, does it actually matter if you are receiving a clinical diagnosis for type 1 MI or not? So here you do see a cumulative incidence plot of myocardial infarction or cardiovascular death. And the yellow line is no myocardial injury group, which is a little bit the control group that we have. And in a way, you would say if they are not receiving a clinical diagnosis, then they should also be at low risk. And if you look at the picture, then there's no question that those patients are at very high risk. And in Scotland, we did even observe that they were at higher risk as compared to those who did receive the clinical diagnosis. And that is also the same we did see for Scotland or for Sweden, that that those patients who did not have received the clinical diagnosis, they are definitely a high risk group. And that is in a way also the same when you are looking at type 2 myocardial infarction, and also knowing that a lot of those patients are not being identified in clinical practice. It's not that they are not at high risk, they are definitely also a high risk group. So if I just go back also to what we have observed in this study, is I find it really striking that for a group like type 2 MI patients, that just 1 out of 5 patients is being recognized in clinical practice as having a type 2 myocardial infarction. And I think that also with the people here in this room, who I will hope that also participate in discussion like Bertil, is that it is such a heterogeneous group of patients. So the answer is not that we should start, in my opinion at least, that we should start an educational program to make sure that everybody's going to recognize type 2 myocardial infarction patients. I think this data also makes us maybe that we should reflect on, are we really doing the right thing with the definition of type 2 myocardial infarction? And for example, there are with type 2 myocardial infarction, that can be due to a coronary mechanism or a non-coronary mechanism. And for a clinician, that is maybe already the initiation that a treatment plan is completely different. So I think that it let us make us think, at least that is my opinion, that I think we should also just carefully look at the universal definition of myocardial infarction again. I did find it striking that we basically did see a very similar pattern in both Scotland and Sweden. And I think that is also making it strengthen our findings. And I think if you also go back to the way how we classify myocardial infarction using the ICD system, I think there's also some improvement and reflection maybe there on the way how we are doing it. I think for those who are not so familiar with it, for this study we have used ICD-10 coding, the 10th version of the ICD classification. This year there has been released the 11th version. And this ICD-11 version is not aligned with the universal definition of myocardial infarction. So the way how we are now basically making our data collection in our hospital record system is whether they have a STEMI or a non-STEMI. And I think it's also very important that we maybe also want to make sure that if you create a universal definition and you endorse that in the international guidelines, that we also maybe want to think about implying that also in our electronic healthcare records, that we also can just identify those patients again. I am here that I would like to share now the camera again with Nick, also to start the discussion.
Move that around and
yeah, and I also would invite Bertil directly to join as well.
Sorry, wide angle, but hopefully you can see us all.
Yes.
Dave.
Fantastic. Thanks very much for the talk. And I see we've got. What I'm looking at is the chat. If you want to put in questions, or you can hold your hand up electronically in the participants list. So post your questions if you've got any. I mean, I suppose while people are thinking about that. So of course I'm a computer scientist. And so, and a lot of this talk has been about understanding what the data tells you about care. But is there anything that this tells you about the kind of further management of data collection? I'm personally very interested in, as I know Nick is, in the use of data continuously in clinical settings. I don't know if there's anything there, or is this just completely independently? You understand it as a trial and what that tells you?
No, I think it does. I think Dorien touched on it at the end there. If we change the classification system for an important common condition and do not align that with the way that the ICD-10 or now 11 categorizes data, then it will be very challenging, I think, to implement and understand how that new criteria has been implemented in practice. And there's always a lag, and it's been a massive, I think, undertaking to move from ICD-10 to 11, or it's about to start. But unfortunately, already, I think the criteria are probably not as good as they could be. So we're going to struggle, I think, a little bit in understanding universal definition using routine data going forward. But I think the discordance tells you that clinicians haven't really embraced the universal definition in the way that it was originally envisaged. And there may be a number of reasons for that, but certainly we need to do further research to understand it or revise it, I think might be necessary. But I would like to think that we could incorporate some additional variables in hospital coding to try and understand this better across the UK. There have been proposals to use a 5th digit for type 2, which have been poorly implemented, I think. And there may be opportunities when we do migrate over to ICD-11 to more systematically incorporate that into practice. So we'll have to be on top of that.
But I think if to incorporate another digit, if you don't have a consensus how you should make this diagnosis, is to fool yourself. I mean, these figures clearly shows that the current coding is not completely reliable, at least regarding type 2. And if you have another figure for that, it becomes no better for that.
Yeah.
So I think the fundamental thing is to have a definition that is recognized and accepted and applied by clinicians. Otherwise, the codes in in clinical practice will not be what you think they are.
Yes, I agree. You could fool yourself, and I think people that have tried to do research using type 2 codes, particularly in North America, I have no idea what those codes mean. It's very difficult for a hospital coder to disentangle this. It's hard enough for a cardiologist that's got a patient in front of them. So it is a tricky area for us. What I was pleased about, though, Dorien, is that for type 1 myocardial infarction, where we have effective treatments, there was pretty good sensitivity for the gold standard, over 80%, and a specificity of 98%. So I think we can be confident that ICD-10 codes for type 1 myocardial infarction are correct, but we may not be picking all of the events up. That's the question. I was going to ask you a question, if I'm allowed. So in the sensitivity analysis, where you restrict the position to the first or second order diagnosis, did you find that the sensitivity was lower, but the specificity was higher? That's what I would have anticipated. And if so, how much lower?
Not much. It was, we didn't see a remarkable difference at all. There is also, our colleague Demetrius has looked at outcomes, and there he found that when you choose the third position, particularly, is the best ones. But for our data, we didn't see no.
Well, that's reassuring, because I think broadly across data research, people tend to do their own thing when it comes to which position to use. And I've often worried about it. So if it doesn't make a huge difference to sensitivity and specificity, then maybe that's okay. I think for heads data in England, there are many more diagnoses that are coded, whereas in Scotland, it's just the first 7, I think.
7, yeah.
Good. Okay, so you can't ask all your own questions. So I'll bring in David Griffiths got his hand up.
Thank you. Thanks to Nick and Dorien. Really enjoyable half an hour for me. Thank you. I've got a quick question for Nick, and then probably a sort of more general question about the approach for, I guess, you all. So the question for Nick was that last slide you presented, where you showed that with the type 2 MI, although you've got greater sensitivity with this test, you've got a higher diagnostic yield, which I suppose might lead on to more investigations and more follow-up for these patients. You didn't actually show a difference in their outcome. So I wondered what your conclusion about the use of high sensitivity troponin overall was for type 1 MI. So that's the first bit.
Well, so my conclusion is that I think it is beneficial as a test, that everyone should use it if they aren't already using it. And I say that not just because of the data that we've shown there, which does demonstrate a different course for patients, particularly with non-ischemic injury, and a trend in the right direction for the identification of type 1 patients. But because we've learned during the rollout of this test what a fabulous test it is to make rapid decisions. And so actually the subsequent trial, which we didn't present, demonstrated that we can send people home quicker who do not have the diagnosis, and confidently and safely, which has a big impact on healthcare systems. So although it can create some diagnostic uncertainty, which I accept, it does help us, I think, with patient flow in a way that the older tests wouldn't allow us to do. So I think there are lots of advantages of it. And I think the fact that there was an improved outcome in one of these subgroups is definitely interesting. And we need to learn, I think, for me, we need to learn about what clinical pathways are relevant in investigations for people who come in with non-ischemic injury. And is that recognition of structural heart disease, or how do we systematically study those patients per deal?
I have a question. Have you looked into what different things, what changed in the group with myocardial injury? What did you do differently? I mean, there must be an explanation for the better outcome.
Yeah, I'm with you there, and it's a very good question. It's a very difficult to answer because the trial was designed as an acute coronary syndrome trial.
Okay.
And captured all the treatments for type 1 MI.
Yeah.
And whether they had an angiogram or an angioplasty. But of course, none of those treatments are indicated in people that have non-ischemic injury. So unfortunately, all I can say is that we were more likely to admit them to hospital, substantially more likely, and that their duration of stay doubled. But they probably didn't get managed by cardiologists. And so any change in care may have been holistic medical care, or it may have been to do with the recognition of heart failure and subsequent treatment for heart failure. But unfortunately, because our trial captured the treatments for acute coronary syndrome, I can't answer the question in the way I would like to be able to. But maybe with additional linkage, if we ever get the approval to do it, we might be able to dig into it. And I'd be in particular interested in to know what specialty these patients were managed by, who can take the credit. I suspect it's not the cardiologist, is my gut feeling. However, but David had a second point.
I won't hog the show. That was brilliant. I'll let someone else ask a question if they like.
Oh, it's okay. That's okay, David. If you have a second one, ask it, because you might not.
Sure. Well, it's just relating to this type, I suppose, the type 2 MI group. So I suppose I'm an ICU doctor, and every now and again we measure a troponin, which is high, and we speak to Nick about it, and we have a sort of, we sort of have a hum and haw a bit about what's going on. But I suppose you only get the test result if you do the test. So I suppose in this sort of approach where your sort of inclusion into the trial is at the point of the test, I guess there's a whole group of patients that we just don't do the test on. So should we be doing more tests? Should we be more suspicious of this this harmful problem? And who do we do the test on?
That's a fabulous series of questions, really. I mean, if I could answer all of those, incredible. What I would say is that, the trial population was restricted to patients whom the clinician who ordered the test said that they thought the indication was for suspect acute coronary syndrome. Now, that is not everyone who had troponin testing in our healthcare system. It's around 80%.
Okay.
But there are a proportion of patients who measured troponin for they felt other reasons. I'm not sure if it's 20% or 15% because we don't have that data because PBAB won't allow us to have it because it wasn't in our inclusion criteria. So there are a group out there that do get troponin testing for other reasons, maybe some of them in critical care. And I think it would be interesting specifically to study what impact there were on outcomes there, because actually, now that we've demonstrated the benefit was largely in people who didn't have type 1 MI, you might find that most of the patients who benefited were in that group. So I'd love to go back and revisit that question. In terms of who should have a troponin test, that is
I was being facetious.
$1 billion question. And currently it's sort of licensed for the rule in and rule out of type 1. But actually, I think increasingly in the future, we'll understand that knowing whether there's injury to the heart, if we can think beyond troponin being a heart attack, might be really valuable in terms of risk stratification and guiding where they go. And probably in critical care, you guys might want to be more likely to see a patient who's unwell on the general medical wards who's got substantial myocardial injury than doesn't, irrespective of what the diagnosis is. Because it might well tell you about multi-system injury that you may not get from other parameters. So if we could think very sensibly about how to interpret it, I think it might have a broader role.
And also a better understanding of what impact it should have on choice of treatment.
Yeah, I think almost certainly patients with acute myocardial injury will have left ventricular impairment, which might be useful in a critical care setting to guide who gets an echo. And even in a less critical care setting where unrecognized heart failure is really common. In fact, I've just come back from the American Heart Association meeting where there were lots of debates and discussions about whether we should be screening for heart failure using biomarkers. Well, we already kind of do it in hospitals, just we ignore the results. So the echo service would need expanded, I think, if we were using it very widely.
Great.
Thank you.
I see we're getting a bit pushed for time. Anybody got any other burning questions? So all that's left for me to do is to thank the three of you. Actually, it's lovely to see an international study being, and I've never actually seen it done, not in this series, with three people together. So that seemed to work quite well. And assuming you're in Scotland, our visitors enjoy the wonderful Scottish weather. Not as good as Sweden, I imagine, but there you go. And
pretty similar.
Oh, I'm from Shetland, which is even further north, so about the same latitude, I think. So thanks everybody for turning up, and see you next time. Thank you.
Thanks, Steve.
Bye.